Starting. All attendees are in listen-only mode.
Good afternoon, everyone. Today's Friday, May 15th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Thank you for joining us. We have several presenters today. Bernie Simons, the Deputy Secretary for DDA, Patricia Sestoki, Director of Programs, Rhonda Workman, Director of Federal Programs, and also today we have Dr. Kenneth Fetter, Epidemic Intelligence Service Officer with the CDC, assigned to the Maryland Department of Health for Prevention and Health Administration. He will be presenting information and guidance specific to working with people with developmental disabilities in congregate residential settings. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There's one option for listening to the webinar, and that's by computer. There's a handout for the webinar, which you can find in the handout section on the right, and they can also be emailed. We will be recording the webinar today and posting it on the DDA website. So now I'd like to introduce Bernie Simons. Good morning. Oh, no, it's good afternoon. Excuse me.
Yeah, okay. All right. Good afternoon. Unless you're in Central Time. So, again, I want to thank everybody who is on this webinar. I think it's extremely important that we continue to engage with each other. Obviously, we're all concerned about each other's well-being, wearing face masks when we're out so that we don't contaminate each other, etc., and spread this. We need to stay working with families, providers, all people who are in supports, whether they are in traditional providers or self-directing or on our microboards. And I want to thank you for your commitment again for being on these webinars. So we've been trying to update everybody on every Friday as best as we can. And why I say that is you'll hear a little bit later where we're trying to put together all of the 800 questions that we have so far. I'd also like to recognize and thank Dr. Kenneth Fetter, who's from the Center for Disease Control. He's been with us on multiple webinars so far, and has been the feedback that we've gotten at DDA he's been extremely informative and very, very positive feedbacks about his presentations and the information that he has presented. And so obviously, our highest priority is everybody's health and safety and well-being. And we know that the governor talked about going into the first step on reopening when he did his press conference the other day. And so obviously we need to figure out where we are. I know that there are certain counties that the county's executives were on television, including the county that I live in, basically saying that they want to be a little more cautious, and it was great, and thank the governor for giving them, as the county executives, that flexibility to not necessarily move and reopen as much as the state is allowing, but again, the individual jurisdictions being able to make those decisions at a local level. And so, we applaud everybody for basically looking at this and obviously concerned about everybody's health and well-being. I do want to say that this upcoming Tuesday that we will be reviewing self-directed services as related to Appendix K. And as you can see on that slide, there is a link to register for that. I'm happy to announce that we at DDA received our third round of personal protective equipment over the last couple of days, and that the regions will continue to engage with microboards, people who are self-directing, and the provider community about getting out those important supplies. And then what we're working on now is we started to work on a recovery plan. And what that means is, what would it look like as we begin to go through the governor's phase 1, 2, and 3 for reopening. What does it look like? What type of guidance do we need to work with? And we actually have been working with the DD Coalition, as well as some recommendations and information from our national people, such as the National Association of the State DD Directors Association. I've had the opportunity to be on calls with about 8 or 9 other states about where are we, and it's from the West Coast, California, Washington, the mid part of the country with Ohio, etc., and then Connecticut, Maryland, and South Carolina, just to mention a few of the states. And so we actually obviously are at a much different place in each of the states, as well as we are with each jurisdiction within the state, and we need to be very sensitive to how we're doing and how we're moving forward. So we will be engaging over the next probably week or so with a handful of providers who will work as a pilot with us as we determine the questionnaire that we want to send out to ascertain where we are with providers, what does it look like, and do we have the appropriate questions as we've had engagement with the DD Coalition. And so that's what this plan's about. And obviously we need to continue, and we have obviously some guiding principles with 4 major areas. Obviously, where are we with day, employment, and transportation issues? Because obviously we're not going to be having, a full van of people together again, or at least for the foreseeable future. What are the financial considerations, and what does that look like? Obviously, you know that there are some financial areas that we put in Appendix K and got approval for from Center for Medicare and Medicaid Services, specifically health and safety strategies, and then what is called Sunrise, which is a phase in, and what are the new possibilities that we have? How do we do business a little bit differently that maybe we learned from being in this pandemic and having to do business differently? And then when we reopen, some of those things still positive with the way we provide supports and services to individuals within the Developmental Disabilities Administration. So again, I think that as we look at these areas, it's extremely important to be able to listen to everybody and to get their input. As far as the regional updates go, in the South region, we have had, and this is as of yesterday afternoon. And so in the South region, we have had 163 confirmed positive. We have had 32 tests that were negative, 2 are pending, and we have had 10 individuals in our support who have passed away. In the East region, we've had 21 positive, 19 negative, 1 pending result, and we've had no deaths. In the Central region, we have had 66 individuals confirmed positive, 78 tested negative, 4 people are pending their results coming back, and we have had 8 people in supports who have passed away. In the West region, we have had 9 people test positive, 27 negative. We are caught up. We have no pending results out there of what was reported to us. And we have had 2 individuals pass away who are in our supports. Back a few weeks ago, we started reporting on what we knew about staff. And I can tell you in the South region, we have had 71 staff reported to us through the Southern region have tested positive, and we have had 4 staff members who have passed away. In the West region, we have had 15 positive and 0 deaths. In the East region, we have had 42 staff tested positive And in the central region, we have had 63 tested positive. And so, again, our commitment is to continue to share information and resources like the PPE, the information that we do on these webinars, and then even with our other meetings we have with the DD Coalition and others throughout the week. I want to stress that we will continue to collaborate and advocate on behalf of everybody that we support, who are in our services, their families, their staff, etc. And we will obviously take a look at, as I said earlier, all of the questions that we have had. And we've got, obviously, we've had the Appendix K webinars. We've done these Friday updates, and we've received questions through our DDA toolkit email site. And so we've got about 800 questions. And what the staff are doing right now is taking a look at that and trying to put it in some type of friendly manner and remove duplication so that people aren't reading 800 questions, but we can get to the source of what is the nature of the question and how do we answer it. And our anticipated date is to have all of these updates answered by next Tuesday. So again, next Tuesday, look for it on our website. It might be towards the late afternoon, but that's our target date that we want to get information out. Again, I want to thank everybody for their patience, their dedication, the collaboration. We know that we're all in this together, and we need to be able to support each other. There was a question that came in, though, that I would like to address right now. And it was some clarification around, is there an increased rate if somebody is isolated? And the answer is yes. And there are a few definitions that we were using, and it was like if somebody is isolated who is symptomatic, it would be one. Another one would be if someone is tested and is awaiting their results, they'd be in isolation. Obviously, if somebody is tested positive, and if someone who's tested negative and still looks symptomatic, obviously we're going to have some type of isolation with those folks. So just so it's clear, there seemed to be a lot of questions that came in about some of those areas. And again, I would ask you to take a look at DDA Appendix K, and that's number 7 that gets into the rate increases. So that's on our website. I hope I didn't go too fast. I'm more concerned with getting my updates out, but I really want you to hear from Dr. Fetter, who again is from the Center for Disease Control and has been working with us and extremely helpful. And again, we've got a lot of positive feedback about his presentations, and we appreciate his collaboration with us. So with that, Dr. Fetter.
Okay, thank you very much, Deputy Commissioner. Can you hear me?
Yes, we can.
Okay, fantastic. All right, so thank you so much to everybody who has joined today for inviting me to join. I'm back to talk in more detail today about preventing outbreaks of COVID-19 in group homes for persons with developmental disabilities. And I just want to be very upfront that what we're going to talk about here is most of what will appear in written guidance that should soon be sent to you in the local health departments. Our goal was to have that guidance out to you today. It's probably not going to go out today, but we didn't want to wait, and I wanted to talk through these things now so I can give you the gist of what's coming, answer questions, but please know that written guidance in a checklist format and guidelines sent to local health departments are forthcoming, and we are finalizing that right now, and we appreciate your patience. Okay, slide, please. Okay, so what am I going to talk about today? So what we've talked about a lot is that a different playbook is required for persons with developmental disabilities in terms of responding to your needs when you have a COVID-19 outbreak. And as always, when I say an outbreak, I mean a single resident of a program or a staff person associated with that program tests positive for COVID-19. So different needs of the population, different program needs, fewer medical resources and less medical expertise on site in your programs than some other programs that may be serving people with COVID-19, less familiarity with infection control practices and less capacity to maybe implement that within the confines of how your homes are set up, which is like homes in the community. And so, like I said, we are putting together these new tools, which are coming soon. But I'm going to talk through right now are the information that appears for the most part will likely appear in that first tool, the checklist for preparing to and responding to outbreaks. Slide, please. Okay, so let's talk about the first step, which is preparing for and preventing an outbreak. So much of this we've already talked about, but I'm just going to talk through it again. So it starts with limiting entry to your programs to essential personnel and having staff wear masks at all times while in the program. Residents should wear masks whenever they can. In other words, if you have a resident who's able to wear a mask while they're outside their room, they should do so. And it's good to practice that as routine and come up with any strategies we can to get residents to wear masks. Some residents won't wear masks, and we understand that, and better is better. The more who can wear masks, the better. So frequent hand hygiene, so that means staff should be performing hand hygiene whenever they go into the home, whenever they leave the home, before they provide any resident care, and then after completing resident care. If they're using gloves, gloves are not a substitute for hand hygiene. So that means they're performing hand hygiene, then they're putting their gloves on, they're providing whatever care they provide, then they're taking the gloves off, and then they're immediately performing hand hygiene again. Now for residents, again, this is another situation where we think building on routines and habits is a good strategy, right? So we want residents practicing hand hygiene as much as possible before, anytime they're about to engage in any activity and after they've completed that activity. Basically the same strategies as for masking. Limiting recreation to physically distant activities. We've talked a lot about this. So that means, solitary recreation is okay. Virtual recreation is okay. It doesn't mean that when you're not in an outbreak setting that everybody has to stay in their rooms all the time, like we recommend for a nursing home. People can go out of their rooms. They can go outside. People are living together in a home, and we recognize that they will interact with each other when they're not in an outbreak setting, and that's okay. If they're going outside the home, they want to be doing solitary recreation, so accompanied by a staff person in a personal protective equipment who can help supervise them and making sure that they're not doing any kind of group recreation or anything that brings them into close contact with others. Cleaning frequently with an EPA-approved cleaner, and in the guidance we send out, we'll send a link that includes a list of what all the EPA-approved cleaners are, but you can review them on the CDC's website. So just making sure that when you're doing that frequent cleaning, you're using a cleaner that actually destroys the coronavirus. And then finally, preparing in advance by training your staff on how to don and doff personal protective equipment. Try to do that as fast as possible, even if you don't have personal protective equipment for your staff yet, because in the event that an outbreak happens, staff want to already be familiar with how to take that equipment off and put that equipment on. And already they should be wearing masks, and so you can review the appropriate ways to don and doff masks, and there are CDC videos for that. And again, we'll be sending the link for those, but if you just search for CDC videos for donning and doffing, you should be able to find this. Okay, so having a plan is critical, okay? So the first step to any good plan is a staffing plan, and that's as much as possible dedicating your staff to specific homes. And I've said this many times, and I'll say it again because I know it's extremely challenging, but it is always the gold standard to work for. The more staff move between homes, the more they spread the virus between homes before you know it's spreading. And so dedicating your staff to a finite number of homes helps protect spread among homes. Know where your residents will live if they test positive or get sick. So this is a key part of planning, okay? So one thing that we really want to encourage you to consider after talking this over is considering setting up a designated home or a space or dormitory or any safe space that's a part of your program that's currently unused or that can be made unused that clients can move to and live in after they test positive until they recover. In other words, moving to an out-of-home isolation model. And this is really designed to address a challenge that we've seen in a lot of homes, which is where as soon as one person tests positive, every other resident within that home tests positive within the next week or two, because we can contain spread between homes by dedicating staff, but stopping spread within homes, which are set up like family-style homes where people are sharing bathrooms or kitchen, is extremely difficult, and it's very, very challenging and often painful for residents to remain in their rooms at all times. And so setting up an out-of-home isolation model, if you have the ability to do this, is something we absolutely encourage you to do if you have access to those resources. If not, then start coming up with a plan in advance for how you're going to make sure residents can be isolated within their homes. In other words, know what you're going to do in the event somebody tests positive. Have an emergency staffing plan if many of your staff are going to become ill or will not work. Then finally, so many of you will have programs that employ a healthcare provider, like a nurse who's on your staff, who will be able to help with test specimen collection once you get specimen collection kits. And we'll talk about specimen collection kits in a minute. If you don't employ a healthcare provider, think about trying to build a relationship with a healthcare provider in the community, maybe somebody who's already serving some of your residents, or maybe it'll be different providers for each resident, but have a relationship with that provider who can assist either with test specimen collection or with writing referrals so that your residents can be tested in the event that you need that to happen. So just being proactive about having a relationship with that healthcare provider in the community. Slide, please. Okay, so how do we identify an outbreak? So we're going to send you a symptom screening tool, and you can use that tool to screen both residents and staff. And so you want to be screening everybody who enters into a home for symptoms. And any staff person or anybody who's going to enter that home who screens positive for any symptom on that screening tool should be excluded, okay? And they should be recommended to seek testing in the community from a testing site or from their primary care provider. So anybody who screens positive for any symptom, they should go and get tested as fast as possible. Now for residents, we want to try to screen every 8 hours, okay? And for any resident who screens positive, we're going to immediately move towards temporary isolation. So that means they should stay in their room as much as possible, should take their meals in their room. If there's a private bathroom they can use, and dedicate a bathroom to that person if possible. If not, if it's possible to set up a situation where they do toileting in their rooms, that's preferred over sharing a bathroom. You know, sometimes folks use a commode. And staff who serve that resident should be wearing full personal protective equipment while they do so. So that means mask and eye protection and disposable gloves and a gown for that resident. And that should be done as soon as that person's identified as sick, while you're still arranging testing. Okay, so let's talk about the testing. Okay, so we want to try to test anybody who develops any symptom that could be consistent with COVID-19 as fast as possible. Now, if your program employs a nurse or another healthcare provider, it's going to be that person's responsibility to physically collect the specimen. And so what they can do is they can reach out to the local health department and arrange to pick up a specimen collection kit. And they should say, I am a healthcare provider for a group home with persons with disabilities with a suspected outbreak of COVID-19. I need a specimen collection kit to test a symptomatic resident. And they should be able to obtain a specimen collection kit from the local health department. And then what you'll do is that healthcare provider will collect the specimen. And then there's CDC guidance for how to collect the specimen. And again, that'll be in the written guidance, but if this comes up in advance, you can look it up. The safety protocols for collecting specimens, it's right there on the CDC website. Collect that specimen and return it to the local health department. And from there, the local health department will make sure it gets sent to a lab for testing, probably the State Department of Health lab, but possibly a private lab. Now, if you don't employ a health professional in your program, this is where it becomes important to have a plan for where you will take your residents to get tested, right? So this means basically having a relationship with a healthcare provider in the community who you can bring your resident to, have a staff person bring that resident to that program. The staff should be wearing full personal protective equipment, or to a testing site in the community where that resident can safely go and have that person tested for COVID-19 at that site. And this is something we strongly encourage you to call your local health department and talk over with them in the event that this is something you need to do. You know, talk about what testing options are available in the community with the local health department. Sometimes it's possible a local health department staff person might be able to come collect the specimen. Typically, that won't be the case. Typically, specimen collection is done by healthcare providers in the community or by healthcare providers employed by a program. And so you should absolutely call the local health department to discuss testing options, and they might be able to help you find community providers. But it's important to have identified a community provider or testing site where you plan to take your residents to if they need specimen collection, and you don't employ a healthcare provider. Build those relationships in advance. Okay, so what is an outbreak? An outbreak is one resident or staff person who tests positive for COVID-19. Within 12 hours of a single positive test, you must report that result to the local health department by calling, and to your DDA regional director by calling or by following whatever process is specified by your DDA regional director, okay? And the health department will assign an outbreak number, okay? So once you report that and say, I have a resident in my program who's tested positive for COVID-19, I have a staff person who's tested positive for COVID-19, they'll assign an outbreak number. If you didn't get an outbreak number, that means that your report wasn't received properly and you want to follow up again and make sure you get the outbreak number, okay? So, they'll say, okay, we're taking that report, we'll get back to you with the outbreak number. If they don't get back to you with the outbreak number, they say they're not going to get back to you with an outbreak number. Follow up again, make sure you get that outbreak number, because that's how you know you have a relationship established with that local health department to support you throughout the outbreak, and then in turn with us, because the outbreak numbers are assigned by us at the State Department of Health, and so that means there's somebody at the State Department of Health who's monitoring your outbreak. Now, I want to talk a little bit about whether, this is not on the slide, whether the outbreak covers a specific home or your network of homes, okay? So this will probably be decided on a case-by-case basis, but oftentimes, because homes are sharing staff, if a staff person is working at multiple homes, and you have multiple staff who are working at multiple homes, typically it's best to jump right to the assumption that you have an outbreak in all of your homes. And if this is all within one county, all within one jurisdiction, that shouldn't be a problem. But if you have staff who are working in homes across county lines, and one of your staff tests positive and they've been maybe working in multiple counties, or other of your staff are working in multiple counties, it's important to communicate that to the local health department so they can communicate that to us, and we can make sure that all of the counties that are potentially involved in the outbreak are involved and are supporting you for the homes that are in their county. Okay, most of the time, hopefully that won't happen, because I think most programs sort of are contained within a single county. But if that does come up, that's an important thing to be working with us and your DDA regional administrator and the county health departments. Okay, so once the outbreak starts, the expectation is that you'll complete what's called a line list. So what is a line list? So it's a daily list of names that gets sent to the local health department where the outbreak is located. In other words, where the outbreak home or the outbreak group of homes, so we just talked about, it might be a network of homes that have the outbreak, okay? You would report on the line list all persons who are involved in the outbreak. So that means any resident or staff person with a symptom of COVID-19 and who should therefore be tested for COVID-19. And then also anyone else who's been tested for COVID-19 for any other reason. And so that's in the event that you decide to do broader testing than just testing symptomatic persons. And on that list, okay, you would indicate the person's test results, the date their test specimen was collected, the date of their symptom onset, the date they were hospitalized if they ever had to go to the hospital, and the date of their death if they should unfortunately die. All that would be indicated on the line list. No name ever gets taken off the list. In other words, it's how we track the progress of the outbreak. It helps us keep track of what's happening in your program, and hopefully will help you keep track of what's happening in your program by keeping an organized list of everyone who's tested positive or tested negative at any point, and updating yourselves and us on their status. And I just want to say, so the expectation is anybody who is sick or being tested is reported. It doesn't mean you have to report people who are not involved in the outbreak. So in other words, the local health departments aren't going to ask you for just the names of every single staff person who works for your program or every single resident in your program. And the other thing that I want to emphasize is that you can report these people's names and you must report their names. There's no confidentiality violation, because anybody who's being tested, we will know their test results. And there's an obligation to report all confirmed and suspected COVID-19 cases to the health department. So this is really just about linking those people to their program so we can serve your needs. We already will know their identities and the fact that they're tested. Okay, controlling the spread. So once somebody tests positive and you've got that outbreak and you've fulfilled your reporting requirements, what steps are you taking to control spread? So the first is full personal protective equipment for all staff in all homes in the network. So that means suppose you've got a home with a single resident who tests positive, but you've got multiple homes in a network that are served by the same staff. And so the resident who were previously, the staff who were previously working in that home, where somebody tested positive, they're working in other homes. And so maybe you've had a new introduction into a second home, but you don't know that yet because nobody's gotten sick yet. That's why it's important to move as fast as possible to wearing full personal protective equipment for all staff in all homes in your network for the duration of the outbreak. Okay, and if that's not feasible because of personal protective equipment shortages, obviously you want to prioritize the homes with known positives and then homes that have been served by staff with known positives. But it's really best to move as broadly as possible, as quickly as possible with personal protective equipment until such time as your outbreak ends. Continue that symptom screening. So once you're in the outbreak setting, keep screening for symptoms, keep testing anybody who develops symptoms. Okay, and you, again, the process for that is the same. You get those specimen collection kits from the local health departments, test anybody who's got symptoms of COVID-19. Implement that isolation plan you put in place for anybody who's positive and anybody who's ill and pending results. So as soon as people test positive, implement that plan to isolate them off-site if possible, or if not, within a separate part of their home. Best is off-site, if not in a separate part of their home. Implement that isolation plan to protect the other residents within the home. And then another thing you want to talk to your local health department about that often will be a good idea is whether it makes sense to test more broadly of residents and staff in a home with a known case. So in other words, you want to think about once one person who either lives in a home or has worked in that home tests positive, do we just want to move forward and test everybody who lives in that home right away, regardless of their symptoms? And that's something you want to discuss with the local health department. And it'll be a decision made based on a couple of factors. First is whether there's availability of test kits. And that's something they can work with, you can work with us on and work with them on. And second of all, it'll be made based on what you're going to do with the information. In other words, if you've got a strong isolation plan and ability to isolate people outside the home, then it makes much more sense to test broadly quickly, because you can quickly take anybody who tests positive and help them move to a safe location outside of the home for the duration of their illness, isolating them from others within the home. If you're already in a position where you have a small home with a small number of residents and all of them are potentially ill, or you have no way to really isolate them from each other, then basically, and you're just going to try to isolate them all within their own homes no matter what, then the value of additional testing is minimal and it may not make sense. So often it will be useful to test more broadly, and that's something you want to discuss with the local health department right away, but it may not always make sense if nothing will be done with the information. Okay, so we already talked about off-site isolation for residents who test positive. What should happen in a home where there's a known positive resident or staff person? So once a home has a known positive resident or staff person, everyone who lives in that home or who's worked in that home is considered exposed. That doesn't mean they're going to get COVID-19. We want to try to prevent them from getting COVID-19, and that's the purpose of that offsite isolation, the use of personal protective equipment, the hand hygiene, all the other things we've talked about, the testing. But some of them could get COVID-19. And so what we want to try to do is we want to do what's called quarantine that home. We want to cut that home off from other homes and make sure that those residents are separated from other people and those staff are separated from other people, so that in the event that they do become sick and test positive, they'll already have been separated from others and they won't spread the virus any further. And so in a best case situation, that means switching to a shelter in place model for a home that has had a single positive resident or staff person. In other words, you're going to have a dedicated staff person who lives on site in that home 24/7 for the duration of the outbreak. And so that way you minimize the total number of staff who are going in and out of that home, and you cut that home off from the rest of your network so that those staff can't spread any residual positive from that home to another home. Oftentimes that's not going to be possible. And so at minimum, what you want to do is you want to give homes that have had known positives dedicated staff. So any home that's had a single positive resident or staff person should have staff who are serving in what we're going to call affected homes. Okay? And any home that is thus far unaffected, in other words, it has had no positive residents and no associated staff people test positive, should have a separate group of staff who have never worked in a home where somebody has tested positive. So at minimum, you want to have those two cohorts of staff, the staff serving affected homes and the staff serving unaffected homes. And one thing that's important not to do, or at least on a very rare circumstances, maybe in discussion with local health departments you would do this, but for the most part you would not do this, is in a home that's had one positive residence, don't take residents who have not tested positive for tested negative and then transfer them to another unaffected home. Because at any time in the 14 days after they've been exposed, they can test positive for COVID-19, even if they've previously tested negative. And what you don't want to do is introduce an outbreak into a new home. Instead, you want to try to protect those people in their home while also cutting off that home from the other homes in your network. Slide, please. Finally, what does it mean to recover from COVID-19? So this is really important because most people who contract COVID-19, the overwhelming majority recover, okay? So when can a person go back to their normal life? And so the guidelines I'm going to talk about govern both when staff who test positive may come back to work and govern when residents who are in isolation because they've become sick or tested positive can leave their isolation. So for a person who's had symptoms when they test positive, they need to wait 10 days after the first day they had symptoms. They got to spend 10 days in isolation from the first day they had symptoms. And then in addition, they need to get better. So if they're still sick after 10 days, they need to stay in isolation until 3 days after the resolution of their fever and 3 days after any other symptoms they've had are mostly better. That's when a person is considered recovered, is when they're at least 10 days past the onset of their symptoms and 3 days after they really started feeling better. Now, what if say you move forward with that model of testing broadly, testing your residents and staff people who have no symptoms, and some of them test positive? What should you do about those people who test positive but never have symptoms? They should be excluded from work or in isolation if they're residents for 10 days past the date of their specimen collection. They should wait 10 days past the date their positive specimen was collected. If they develop symptoms at any point during those 10 days, they should follow the symptom-based guidance. Otherwise, if they make it 10 days without symptoms, they're good to go. When does the outbreak end? So the outbreak doesn't go on forever. It ends when no new residents or staff in any of your homes have tested positive for 14 days. So 14 days with no new onsets and no remaining tests are pending. In other words, if you've made it 14 days with no new onsets, but you've got some pending tests, we keep the outbreak open until such time as you have all your test results back. When the outbreak is over, you confirm with the local health department that you have in fact met that criteria. You stop reporting daily to the local health department on your line lists, and you just switch back to those preventing and preparing strategies like trying to do physical distancing and universal masking. Finally, I just want to talk a little bit about what is the role of the local health departments and summarize some of the things that we've talked about. So what are those local health departments going to be doing with you? So they're your most important point of contact. They're going to be helping you track your outbreak. They're going to be helping to ensure that essential information like the number of infections you have and the number of deaths in your program gets reported in a timely manner, because that's how we as the state know what's happening in your programs and we use that data to inform our recommendations and inform the public. Making infection control recommendations. So they'll be able to help you think through all of the individual nuances of your program about how you're going to do infection control in your program. Facilitate access to personal protective equipment whenever available, right? So they're going to walk you through that process for putting in personal protective equipment requests. And if it's not available, another resource for you there is to go to your DDA regional director, but also working with local health departments on PPA. providing specimen collection kits whenever it's possible. So they're going to be the ones providing you with special specimen collection kits when you need to test an individual resident, in this case, or an individual resident in that case, because they develop symptoms. And finally, facilitating access to those GO teams. So remember, we've talked about National Guard GO teams. Those are a resource for you. If you think you have a widespread outbreak and you need to test a lot of residents, the GO teams are an option. If you want an independent infection control assessment to come in and help you think about how you could change your practices to control spread, you can put in a GO team request. If you are having a staffing crisis and you're worried that, residents are sick in your home and you're not going to know if they're really sick because you just can't physically get enough staff on site and you're worried somebody might need to go to the hospital but they wouldn't be otherwise taken, that's why we have GO teams. That can happen during a COVID-19 outbreak, and the GO teams are there to support you in the event that that happens. So being in close communication with the local health department can help us be prepared and help them be prepared to know when that might happen and when to work with them to put in that GO team. That's it. That wraps up all of my slides. So I appreciate your patience. I know this was longer than some of my other presentations. I'm now available to take any questions that you may have. Thank you so much.
Okay, thank you, Dr. Fetter. I'm going to read, there's lots of questions. I'm going to read all the questions related to your presentation, and the ones that are related to DDA specific, we're going to put in the DDA tool email and respond to you for those by next Tuesday. So the first one is, do you recommend that staff wear masks even when residents and other staff are not present, such as during awake overnight shifts?
Let me think. Awake overnight shift. So that's like residents are all in their rooms and they're in bed, but staff are on their own in an overnight shift in the home.
Correct.
Yeah, I think as long as you're cleaning frequently touched surfaces, well, let me take it. Yeah, I think we would, masks are better. Masks are better because they stop respiratory droplets in the event that that staff person is sick and they don't know it yet. If staff are sort of alone in a separate room and they're awake and they're doing their own thing and they're not near residents, they don't need to be wearing a mask at all times. But it's good to be prepared. They need to have it on hand in the event that a resident leaves their room or could come into close contact with that staff person. They should be cleaning up surfaces, when they're done in that space, obviously. The masks are really for when they're could be within 6 feet of another person, for preventing those respiratory droplets spreading from one staff to another person. And then the rest, there should be minimal other risk other than just by cleaning up. So, anytime that they could be in contact with a resident in the home, they should be wearing the mask even if the resident's not near, in case the resident might suddenly come near. They want to be prepared. But if it's like an awake overnight shift where the resident's in their room and the staff are in the living room, it's obviously always safer to wear a mask in the event the resident comes out. It protects both resident and staff person, but that they don't have to be wearing a mask when they're completely alone, just like in there.
If a person tests positive, by the time you get the results, everyone else in that home has been exposed. You would still remove the positive person?
Yeah, so that's a great question. Okay, so that's the goal of the screen, isolate, test, offsite isolation if possible approach. Okay, so the idea is you screen all your residents as frequently as possible. As soon as that first person tests positive, try to do isolation. Excuse me, as soon as that first person screens positive, in other words, they have a symptom, you don't know their test results, try to move to an in-home isolation, where they go into their room and they do everything as much as possible in their room, meals in their rooms, private bathroom, stay in the room as much as possible. That's to protect the other residents in the home. And if those residents can stay in their room, that keeps them safest too. It keeps them out of the environment. You want to get those test results as fast as possible. The idea is that by doing that in the room isolation while those test results are pending for 24 to 48 hours, you're protecting those other residents. And then the other thing that's protecting them is the use of masks, to the extent that masks are possible. As soon as that resident tests positive, we've taken every measure that we can to protect those other residents. There was probably some exposure there. But the thing we've learned about COVID-19 is that the real risk comes from extended close contact in an indoor environment. And more is always worse. And so as soon as we find out that somebody is positive, it may not prevent spread by moving them out of the home in your instance, but in some instances it will. In some instances it will. It's always better to try to do more, even if sometimes our best efforts don't work. So once that person then gets their positive result, if it's possible to move them to a separate location where only people who are known positives live and care for them in that separate recovery location, that's good, because it can potentially protect the other residents and staff who remain in that home in the event that they haven't been infected yet. Even if they were exposed, they might not have yet been infected, and continual exposure increases their risk. And you would continue rescreening those folks and then testing them if they become symptoms, or possibly testing them all proactively right away. That's something to decide in consultation with the local health department. For everybody else who's in the home, you want to keep them in that home, right? So that means quarantining that home and moving to a shelter-in-place model for the duration of the outbreak. So that's the piece where those folks are already exposed in spite of all of our best efforts. Some of them might test positive, so we want to limit spread between homes.
Okay, the next one is a couple of questions within one. Do nurses need specialized training to complete the test? And what are the risks to the nurses in terms of exposure if they are now testing individuals who may be positive? And will doctors no longer need to order the test if the nurses are now able to request the test?
It's a great question. So different pieces to that. Okay, so let me take this one by one. So when your nurse is physically collecting the test specimen, what it is, the test specimen is a nasal swab. I'm sure many of you guys have seen these done now or seen them on the news, or maybe even had them yourself. And so your healthcare provider will know how to do a nasal swab. The key thing is that they want to do the swab in a way that keeps them safe because they're interacting with somebody who might have COVID-19. And so what that means is they need to wear full personal protective equipment while doing the swab. In other words, they should be wearing a mask, eye protection, gloves, and gown while actually collecting the swab. And so there are CDC procedures for what to do when you're collecting the swab. And your healthcare providers affiliated with your program should review those protocols so they know how to keep themselves safe when they're collecting the swabs. In general, collecting a swab is not considered to be a high-risk procedure as compared to any other healthcare provided to a person who might have potentially have COVID-19. So they absolutely must be wearing full personal protective equipment when they collect the specimen. But that's just because they're in close contact with a person who might have COVID-19. Now, in terms of who needs to approve the testing, so let me talk a little bit about getting the testing, okay? So when you get a test kit from your local health department, okay, in other words, your local health department, you go get that test kit from the local health department, you give it to the health professional affiliated with your program, they collect the specimen, they drive that kit back to the local health department. The local health department has approved that test, and then they will send that test specimen to a lab, and they'll probably list the physician from the local health department as the ordering physician on that test, and the test will be run. Or they may list the nurse from your program as the ordering clinician, and the results will be sent to you. And that's something you want to work out with the local health department in advance, is who is the ordering clinician when it's sent to the State Department of Health lab. If you don't have an affiliated healthcare provider who is able to collect the specimen, then you're going to need that specimen collected in the community. And this is where, I'm going to be honest with you, we are still working out the kinks, okay? But basically, if somebody is sick, okay, they should request that the primary healthcare provider that you work with in the community, or their primary healthcare provider, either collect that specimen or write them a prescription to have the specimen collected at a community testing site. And they should be able to have that specimen collected, because if you're testing them, it means they have a symptom and you're suspicious for COVID-19. Now, once you've got that first positive and you're thinking about testing people who are asymptomatic, obviously that's something that's more difficult to do in the community because physicians may not be writing prescriptions for that, the testing sites won't see them. So in that instance, that's where you want to be working with the local health department to see if they can either provide the kits to do the asymptomatic testing, or more likely requesting a go team. So when you're doing that broader testing, and you want to test a lot of people who might not have symptoms, that's where you're requesting a go team. But for that first instance where you're just testing people who have symptoms to try to get that first case or get that second case, you're either getting the specimen collection kit from the local health department and returning to them, in which case it will be run, or you're building that relationship with the outside healthcare providers so you can right away have them collect the specimen or write the prescription to take them to a testing site and have the specimen collected at the testing site. And again, that's something that the process can be worked through with your local health department, who will know about the testing resources in their own community best. And if you're running up against a wall, in other words, you feel like you're being bounced back and forth and it's been 12 hours and your resident is sick and there's no solution to testing, it's appropriate to elevate. So talk to your DDA regional administrator. You can even, they'll get in touch with me or with a counterpart at the State Department of Health. The last thing we want to happen is that a sick resident stays in a home for an extended period of time without being tested until they end up being testing positive in the emergency department. The testing logistics should be easier, and all I can do is apologize and say we're doing everything we can to make this as easy for you as possible within the constraints that we're operating in, but don't hesitate to keep elevating and keep pushing to try to get your residents tested. We want to figure out how to do that. So follow all the process that I just described, plan in advance, have a partner with a healthcare provider in the community. We think that will help address most of the test shortage issues.
So,
don't be afraid.
Dr. Fetter, there's several questions about the local health departments, and I'm going to summarize it in a couple of statements. Some providers have reported to the local health department, and they have not received anything, an outbreak number. They've also have turned in a line list to the county for people who've tested positive. And they also have not had a lot of same information shared between local health departments. And they're saying that local health departments are saying that the outbreak is determined by the positive test of COVID in a resident, not staff.
Okay, so let me touch that last point first, okay? So a positive resident or staff person who has worked with residents, and if it's like your program director who doesn't work with residents, that's not an outbreak. But a staff who's serving residents, a single positive case is an outbreak. Along with the checklist we're sending you, we're sending out a memo to local health departments that states that. And we've already stated it and we're continuing to state it. If you reported what you think is an outbreak, in other words, a single case of positive instance of COVID-19 in a resident or staff person, and you haven't received an outbreak number, call the local health department again, say, we have had a positive case or multiple positive cases of COVID-19 in a resident or staff person in my program for adults with disabilities. I was told by the State Department of Health that this meets the definition of an outbreak. Please follow up with the State Department of Health to assign an outbreak number. And they will follow up with us, and we will either assign an outbreak number or sort out whatever confusion may have led to it actually not being an outbreak. So for example, one instance where I could see it not being an outbreak is, let's say 16 days ago, you had a staff person who tested positive, but you weren't aware of the reporting requirement or were trying to protect staff privacy or whatever. And so it was never reported to the local health department, and you've never had any other positive or sick residents. And now you've just called the local health department and said, hey, I just went to this webinar and I just learned I'm supposed to report positive staff person. So I had this positive staff person who tested positive a month ago. We're not going to open a new outbreak for your program because you haven't had a positive resident or staff person in 14 days. And so the outbreak that we would have opened before would already be over because you've made it 14 days with no new onsets. So that's a situation where you should still report it just so we're aware of it, but then that would probably just be the end of it. Again, we are sending out a memo to local health departments along with the guidance that we're sending to you to try to clarify some of these protocols, which will hopefully streamline processes across the local health departments and make sure that outbreaks are assigned an outbreak number, and that they send you a line list test template and support you and explain their expectations for you providing them with a line list and help you with go teams and all those things.
There is an emerging research suggesting that case resolutions such as this comes not at the 14-day mark, but rather at the 26 days. On what is the 14-day resolution time frame based?
So there's two, sure. So it's a fair question. Okay, so let me talk a little bit about our understanding of the science. Okay, so I'm going to draw a distinction between two different concepts. The first is the incubation period of the virus. Okay, which is the time between when that virus enters your body. In other words, when you're exposed to the person who gives you the virus, and then when you actually get sick. That's what's called an incubation period, because the virus is incubating in your body.
Dr. Fetter, thank you so much. I think once we put out all the actual documents, we can probably do another session if we have specific questions. There is a couple of healthcare providers and the doctor that we work with. Questions, so I've asked them to send it to us, and I will connect them directly to you. So
That
really do
sounds
appreciate your time and dedication. Thank you, everyone.
For everything you do.
Bye-bye.